Welcome. Welcome. Today's March 6th, 2024. I'm Stephen Resnikoff. I serve as a professor at the DePaul College of Law here in Chicago and as director of its Center for Jewish Law and Judaic Studies, JLJS. JLJS provides programming on issues that are especially, but certainly not exclusively, important to the Jewish community. It can only offer programming because it's financially supported by private donations. We sincerely thank everyone who has been moved to help us. And of course, we are especially grateful to the members of our advisory board. Many of you have probably come to our programs in the past, and we thank you for your continued support. For some of you, however, this may be the first time you've joined us, and we hope it will be the first of many. The opinions expressed by me and by others are the personal views of the speakers. They do not necessarily reflect the views of DePaul University. Today's topic addresses DEI, an acronym that stands for Diversity, Equity, and Inclusion. Ironically, DEI policies and instruction far too often results in discrimination, exclusion, and iniquity. DEI policies harm Jews, harm persons of color, and harm non-persons of color, sometimes in the same ways and sometimes in different ways, but all of these groups can be affected detrimentally. Today, we are honored to have Dr. Stanley Goldfarb share his wisdom with us. His topic is examining the effects of DEI on the field of medicine. Dr. Goldfarb is a professor emeritus and former associate dean of curriculum at the University of Pennsylvania's Perelman School of Medicine. Dr. Goldfarb, who is chairman of the board of the organization Do No Harm, has published over 100 articles in peer-reviewed medical journals and more than 150 invited reviews and commentaries. He's truly an expert on DEI and the field of medicine, and he's testifying tomorrow on this topic before a congressional committee, the same one that recently grilled the former president of the University of Pennsylvania and the former president of the Harvard University and the president of MIT. Before turning the virtual podium over to Dr. Goldfarb, let me explain how we're going to proceed. Dr. Goldfarb will provide some prepared remarks, after which we'll take questions. If you have any questions while he speaks, please write down the questions using the Q&A button you see at the bottom of your Zoom screen. During the Q&A session, please raise your virtual hand. You do that by going to the bottom of your Zoom screen, checking on the smiley face that says reactions, and then clicking on raise hand. With that said, it's now my pleasure to turn things over to Dr. Stanley Goldfarb.
Well, thank you very much, and good afternoon. I'd like to thank Dr. Resnikoff for this kind invitation and the opportunity to speak with you about the crisis that's unfolding in American medicine and, in fact, in American life in general. My interest in the impact of the so-called diversity, equity, and inclusion regimens, or DEI, began about 8 years ago when I realized that my medical school, the Perelman School of Medicine at the University of Pennsylvania, had embarked on a new direction driven by its new senior leadership. I was serving as the Associate Dean for Curriculum at that time, and the new plan was aimed at drastically altering the medical education program at Penn. What had been a traditional approach focused on clinical science and aimed at developing medical leaders was being readied for transformation into a far greater emphasis on community involvement and concern for social issues. The rationale for this was the hypothesis that the root cause of disparate healthcare outcomes between minority, particularly Black, and majority communities was the result of bias on the part of physicians and healthcare institutions. And only through a dramatic reimagining of the practice of medicine, the hypothesis continued, could these disparities be eliminated. In many professional fields, academics is divorced from the world of practice and has little influence on the community of practitioners. Medicine is quite different. You may disagree with this, but the goings-on in law schools have traditionally had little to do with the actual practice of law and have had minimal influence on it. The same is true in many fields of endeavor. But the academic health center is the driving force in local healthcare and has great influence across the nation. American academic medical centers have been the engines of advances in the treatment and cure of diseases, What happens in academic medical centers doesn't stay there, but diffuses out into the larger community. As it turns out, the expanded focus on social issues in medical care was well established in other medical schools, and our school was rather late to the game. We did have courses that discussed some aspects of West Philadelphia, a very heterogeneous community with large and varied immigrant populations, but this was felt to be insufficient by the new leadership. The new vice dean of the med school told me that there was, and I quote her here, too much science in the curriculum. My concern about the new initiative to modify Penn's curriculum led me to speak out on this issue. So did my growing awareness of the fact that medical schools around the country were much further along in adopting an approach that seemed to echo the curricula of schools of social work. I felt that medical school curricula should maintain a strong focus on medical science, should increase its rigor, and should concern itself with turning out the highest quality physicians who would care for those suffering from illness. I also felt that while social factors are important in defining quality of life in communities, physicians had no agency to influence such issues as poor housing or community violence. It seemed that the purpose of raising these issues was to create advocates for political solutions to these problems, rather than educating physicians to improve healthcare outcomes. In 2019, I wrote an op-ed in the Wall Street Journal about my sense that medical education was heading down a path that would weaken American healthcare. The Wall Street Journal decided to entitle that article, "Take 2 Aspirins and Call Me by My Pronouns." This title, not my title, but theirs, elicited a rather strong reaction on Med Twitter and really began my new career as an activist. This background explains why I'm here today speaking with you about this issue. 4 years have now passed, and increasingly the impact of DEI programs that focus on identity politics in the recruitment of medical practitioners and on the manner patients are to be treated has become increasingly evident. Recently, Wesley Yang, one of the editors of Esquire magazine, posted my article from 2019 on Twitter and commented, "Shouldn't we have listened to him then? It is tough being Cassandra, the mythic Greek figure who could predict the future, but no one would listen." So what is happening to American healthcare in the DEI era? We've begun to see the impact of identity politics, a phrase that I feel describes the underlying principles of DEI. Yascha Mounk has written a new book entitled The Identity Trap. He, a self-described liberal and a professor of political science at Johns Hopkins, decries the impact of identity politics on American life. I quote from his book, "The identity trap poses serious dangers. It undermines important values like free speech. Its misguided applications have proven deeply counterproductive in areas from education to medicine. If implemented at scale, it won't provide the foundation for a fair and tolerant society. It will inspire a zero-sum competition between mutually hostile identity groups." His concern, which I share, is that this political and philosophical theory, known as critical race theory, paints a hostile and irredeemable society based on oppressors and oppressed, and will lead to division and conflict. It will poison the American experience. I think we can discuss this from 2 perspectives: the impact of identity politics on the practice of medicine and the impact of identity politics on who can practice medicine. Healthcare disparities between minority and majority populations are real and of legitimate concern, but attributing them in large part to the Black community's oppression by white males and the healthcare system in general is without proof and without merit. As Monk points out in his book, once group identity is viewed in the formulation of either being oppressed or an oppressor, a fixed set of responses ensues. Oppression is unending and can only be overcome through conscious and illiberal actions. Accepting this formulation requires, in the words of Ibram Kendi, a discriminatory regimen. To quote him, "Past discrimination can only be remedied by present discrimination, and present discrimination can only be remedied by future discrimination." During the COVID pandemic, we received a taste of how all this could play out. When monoclonal antibodies were a potential life-saving treatment for severe cases, two states, California and New York, created guideline algorithms that gave points toward justification for the use of the drugs in particular cases based on race. The use of the scarce drugs would be determined in part based on skin color rather than purely on medical need. This violates the Hippocratic Oath, but is in concordance with critical race theory. In the second instance, the Centers for Disease Control, the CDC, recommended to states to give essential workers access to the mRNA vaccine even ahead of the elderly on the grounds that older Americans are disproportionately white. Amazingly, some of the most prominent medical institutions, such as the American Public Health Association, the American College of Physicians, and the American Medical Association, supported this approach with amicus briefs when it was challenged in the courts. These two examples show how simply enacting the principles of critical race theory can have a profound impact on the lives of individual Americans. But at least in these cases, there was no attempt to hide the rationale behind the actions. There was complete acceptance of racialism. What's more concerning has been the misuse of medical studies to justify unequal treatment on the grounds that it will improve healthcare for minority groups. Let me describe two examples. Physicians at a major Harvard teaching hospital published a study claiming that there had been discriminatory practices in the emergency room in the treatment of patients who entered with a diagnosis of congestive heart failure. Approximately 57% of white patients who entered with that diagnosis were referred to a cardiology specialty service in the hospital for cardiac care. Approximately 45% of Black patients with the same diagnosis were referred to the specialty unit. The alternative unit for admission was a general medical unit. This discrepancy, 57 versus 45%, was presented as proof of racism and led them to propose a new paradigm for care. Black patients would be asked which unit in the hospital they wished to be admitted to. Now, as it turns out, and is often the case when comparing two populations of patients, the individual characteristics of the patients govern treatment protocols rather than their skin color. In this instance, the Black patients suffered disproportionately from chronic kidney disease and were being treated with renal replacement therapy using hemodialysis. Such patients are better treated on the general medical unit, where hemodialysis treatments are effective in controlling heart failure and are more easily arranged. White patients disproportionately had their heart failure on the basis of intrinsic cardiac disease, which required special procedures only available in the cardiac unit. The researchers apparently ignored the role of these patient characteristics in the admission decision and instead blamed it on physician bias. They never asked the emergency room physicians why they admitted patients to one unit versus the other. They accepted the oppressor-oppressed binary of critical race theory, that critical thinking was out of the question. Rather than focusing on the individual patient characteristics, their new paradigm was to focus on skin color, even though this could possibly lead to worse care because of admission to the wrong unit in the hospital. Now, ultimately, this approach was not enacted, but currently the electronic medical record prompts any admitting physician to consider the past discriminatory practices, which were, in fact, not discriminatory. A second example comes in the recent enthusiasm for the concept of patient-physician racial concordance. Organizations such as the Association of American Medical Colleges have written that disparities Black patients experience in health outcomes can only be remedied by having a Black physician. They typically cite one or two studies that they claim show a benefit, again misinforming other practitioners and the public. Careful study of the medical literature of this issue reveals a very different picture. Our organization, Do No Harm, about which I will speak shortly, has examined this issue in a comprehensive study by our Director of Research, Ian Kingsbury, and Jay Green of the Heritage Foundation. They have found that the sum of the medical literature does not support the claim that health outcomes improve if Black patients have Black physicians. Organizations that claim this to be true are simply ignoring facts in favor of an unproven theory. Critical race theory will do that to you. It will demand ignoring facts to support the oppressor-oppressed dyad. For example, there are 42 studies of whether Black patients and Black doctors communicate better than when the dyad consists of a white physician and a Black patient. 6 studies show more satisfaction with communication by Black patients when they have Black physicians. However, 8 studies show worse communication when Black patients had a Black doctor. And 26 studies showed no difference when the physician was white or Black and the patient was Black. Yet DEI bureaucrats claim that more Black physicians are required in order to improve health outcomes. The divisiveness that Yascha Mounk described in his book, The Identity Trap, is on display here. Do we want white patients entering healthcare institutions and demanding that they only see white physicians? I witnessed bigoted patients making such demands during my days as a clinician. When patients made such demands at our hospital, we told them to find another hospital. Another consequence of this model is the conclusion that Black patients don't seek the best medical care and are more interested in the race of their healthcare providers. How demeaning to Black patients. The concept of racial essentialism as a guiding force in American life will only lead to more conflict because individual characteristics become sacrificed for group identity. Mounk calls this idea an identity trap, a trap because it seems attractive on the surface, but once entered becomes difficult, if not impossible, to escape. There are many other examples of how the medical literature is being distorted in the service of critical race theory and its demands that so-called anti-racism be practiced to improve healthcare outcomes. In reality, the solution to healthcare disparities is not ineffective or counterproductive implicit bias training for physicians, but rather it is better health access for patients. Minority communities do not need different healthcare, they need more healthcare. The second area where critical race theory and its implementation through DEI and identity politics will have a profound influence on healthcare is through the admission process into medical school and the promotion process for faculty. We have been told the rationale for seeking a medical school class whose components perfectly fit the racial distribution of America is better healthcare outcomes. We have been told by the AMA, by the American College of Physicians, and by the Association of American Medical Colleges that diversity improves healthcare outcomes. They say this, but they have no data to support this idea. Is diversity the most important factor in recruitment and hiring for pilots? What about neurosurgeons? There are certain societal roles where merit and only merit should be the basis for entry. In most debates about school admissions, the discussion centers about the interests of the school and the interests of the student. In certain critical professions, however, a third party must be part of the discussion. In healthcare, it is the patient. When considering entry into medical school, the individual patient's interest must be a primary concern. Unfortunately, identity politics declares that the student's race must be an important determinant. While it is true that the recent Supreme Court decision in the case of Students for Fair Admission versus Harvard seems to have eliminated so-called affirmative action as a basis for admission to university, many medical schools have announced their intention to ignore this principle and to produce workarounds to allow continued efforts to increase racial diversity. Part of the justification for this brand of affirmative action is that if students can pass minimal competency exams like licensure exams, then they are qualified to be physicians. Therefore, seeking out the best and the brightest who have been particularly successful in their academic pursuits is really not necessary to produce adequate health care. But this is not what patients expect. No matter what their racial background is, patients expect and should receive the highest possible quality of care. Academic achievement by physicians is an ingredient in creating a highly effective physician workforce. I have maintained that medicine is a highly academic pursuit. I point out to students that the way we test their knowledge is through multiple choice questions on exams. In this model, there is a STEM, a short statement about a particular patient or a particular medical condition, and then a series of 5 distractors or possible explanations to the origin of the clinical problem. Their job is to pick out the right answer. And I tell them that when they enter the clinics and begin to see patients, they will be constructing the multiple choice question. They will gather the information required for the STEM or description of the problem. They will then produce 4 or 5 alternative possibilities to explain the problem and pick the right one to properly care for this real patient. This is an academic process. This requires maintaining much information about illness and about the variability of human response to it, and it requires judgment that is embedded by a strong understanding of the basic principles underlying the clinical problems that they encounter. This activity requires a nimble mind and the commitment to learn a vast amount of information to deal with patient problems in real time while in the presence of the patient. There is no time to retire to the library to learn about the patient's problem. How has the healthcare system and academic medicine responded to this challenge? They have decided that it is more important to pick students based on racial characteristics, and it is more important to have a racially diverse core caring for patients in various medical specialties than it is for identifying the most capable individuals to take on those roles. To achieve this diverse system, there has been a growing movement to eliminate traditional academic qualifications for entry into medical school and for selection into the most competitive postgraduate training programs. The MCAT, the achievement test for medical school entry, now includes more social science and less hard science. The Council of Deans of Medical Schools has now decreed that grades will no longer be reported for the licensure exam that has been used as an achievement test to determine merit and likelihood for success in most of the most challenging medical specialties. This minimal competency exam is now pass-fail. They expressly state that the reason for this rule is to increase the numbers of minority applicants who succeed in gaining places in the most competitive education programs.
Why this? It's from the DePaul University. About what? What's it about?
This downgrading.
What's DEI?
I think someone needs to.
From DePaul.
You need to mute. You need to mute.
Please, how we're getting young.
Please mute your computers because we're hearing your discussion. This downgrading of academic performance and reliance on so-called holistic measures to determine admission to medical school is already leading to evidence of decreased performance in the clinical arena. There are now 2 large studies that show that minority residents perform less well. In a survey of 3 institutions' internal medicine residency programs and in a nationwide study of emergency medicine trainees, minority trainees as a group perform less well in multiple assessment domains, including professionalism, medical knowledge, and preparation for practice. This is not to say that there aren't very high-performing, high-quality minority individuals who are entering these fields, but rather it says that the education programs and medical schools, in some instances, have sacrificed merit in the name of identity politics. There are 22,000 medical students entering medical school each year. This is a zero-sum game. There are 44,000 applicants for positions in medical school. So if someone doesn't get into medical school, there's not necessarily going to be a space for them somewhere else. If a qualified applicant is not admitted in favor of an unqualified or lesser qualified one, that qualified individual may never have the opportunity to become a physician. It is not like undergraduate years where individuals have a multitude of options for their education. In 2022, the Association of American Medical Colleges compiled a report on its diversity, inclusion, culture, and equity inventory, a list of 89 DEI policies it wants to see implemented at medical schools. Through Freedom of Information requests, my organization found that most have implemented at least 81% of these demands, and many are close to 100%. For example, some schools engage in the practice of having faculty and staff sign diversity statements with the goal of identifying anyone who opposes DEI. To see where that leads, look at Washington University's medical school, where a lecturer threatened students not to debate her on critical race theory. This was the essence of compelled speech. The drive for diversity in medical school classes has led to a concomitant decline in the rigor of medical education. I believe these 2 issues are linked and mutually supporting. 50 years ago, the attrition rate of medical students averaged 9% nationally, although it was as high as 14% in some schools. Today, the attrition rate in medical education is 3%. This reflects an unwillingness to remove all but the most egregious examples of academic failure from medical school classes. Grading in the preclinical years of medical school is now almost universally pass-fail. At Harvard, in a recent graduating class, 92% of the students received an honors grade for their clinical work. When this occurs, there is essentially no such a thing as honors and no real grades. The fault for this set of circumstances lies with both the faculty and the students. Faculty feel compelled to guarantee that students can pass the curriculum and graduate. Faculty performance is graded by students who tend to downgrade faculty members who demand extreme rigor in classwork. So too has the recruitment and promotion of faculty been diminished by DEI. Many medical schools now actively declare that they specifically seek to hire Black faculty. If they can identify highly qualified faculty that happen to be Black, that's one thing. But if they choose faculty on the basis of race, that is no different than denying an opportunity on the basis of race. The DEI regimen also demands that faculty seeking promotions be able to demonstrate not only that they support diversity, equity, and inclusion, but that they have actively worked to promote this divisive idea. This is an example of compelled speech at institutions that purportedly honor freedom of speech principles. The idea that research faculty should also adhere to DEI principles and that the recruitment of such faculty should be closely overseen by representatives of the DEI offices in medical school is particularly absurd. The privilege of performing research, particularly laboratory research, is reserved for those with both the drive and the intellectual capacity to be creative and to make important contributions to the health of the American people. There is no rationale for injecting a diversity requirement in recruiting individuals or promoting individuals who are scientists. The NIH has recently downgraded the role of faculty expertise or institutional resources in determining who will receive the highly competitive individual research grants. Sacrificing merit on the altar of diversity can only lead to a less meritorious scientific enterprise. Lastly, I would like to slightly divert this discussion to confront the most recent manifestations of DEI in the outpouring of anti-Semitic vitriol in America. The healthcare system, unfortunately, is well represented in those tearing down posters of kidnapped children and those equating the slaughter and rape of women, children, and the elderly by Hamas terrorists with Israel's legitimate efforts at eliminating a barbarous enemy. Medical organizations like White Coats for Black Lives have expressed support for the atrocities that Hamas is so eager to publicize. There is a clear nexus between identity politics, diversity, equity, and inclusion programs, and anti-Semitism. In each case, traditional Judeo-Christian ideas about morality have been replaced by the tenets of critical race theory. Simply judging Israel as the oppressor eliminates all responsibility for even the most barbarous actions by the oppressed Palestinians. In this way, the vile declarations by physicians on social media who praise Hamas terrorism are substituting critical race theory for traditional morality and reliance on facts to make moral judgments. Thus, the actual independence of Gaza after Israel's withdrawal in 2005 is called occupation. The movement of over 17,000 Gaza residents each day into Israel for employment on October 6th is called an open-air prison. And some of those employees worked in the kibbutzim that were subsequently attacked, and those Gazans supplied intelligence to the attackers about where to attack. The killing of young women, children, and the elderly is justified as though they are part of the oppressor class. The values passed down to Western civilization through the Decalogue are now replaced by critical race theory as our moral compass. I would like to conclude this rather morose view of the effects of DEI on the world of medicine by highlighting some hopeful signs. In April 2022, we founded Do No Harm, a nonprofit organization devoted to combating critical race theory corruption of healthcare. It's a membership organization of which I am the chairman, and it now numbers over 7,000 healthcare workers and concerned citizens as its members, and we have members in 14 countries. We have worked to inform the public about the danger through more than 4,900 mentions in print and online media, 25 op-eds and editorials in the Wall Street Journal, Washington Post, and other top outlets, and over 50 appearances on television. We have strived to contain the DEI regimen through legal and legislative efforts around the nation. We have initiated 7 lawsuits against defendants like the Medicare system, Pfizer, the Journal Health Affairs, the State of Arkansas Medical Board, and the State of California. In conjunction with our senior fellow, Mark Perry, we have initiated hundreds of letters with the Office of Civil Rights in the Department of Education, protesting discriminatory fellowships and scholarships in a variety of public and private institutions, many of which bar white and Asian applicants. We recently blew the whistle on UCLA Medical School for holding racial caucuses in a mandatory course. And finally, we have worked with leading national law firms to generate model legislation to combat DEI activities in a variety of public institutions that depend on state support. Over and over again, we have found support in physicians and students in many medical schools and academic medical centers. They understand the danger that DEI poses to the American healthcare system. They object to the divisiveness and the discriminatory practices that the DEI regimen promotes. Some important commentators have begun to express hope that the, quote, woke mind virus, in the terminology of Elon Musk, is beginning to face serious questioning. The recent American descent into anti-Semitism has been directly tied to the identity politics at the heart of DEI. When we stop seeing people as individuals and relegate them to group identity, bigotry and hate are the next stage of social evolution. The public is starting to notice this consequence, and that spells hope for the reemergence of the American idea of individual value and individual responsibility. Thank you very much for your attention. I'll be happy to answer some questions now.
So anybody who has questions should raise their hand, their virtual hand, so I can see it. You get at the bottom of your screen, you see a smiley face. If you click that, then you get to another click button that says raise hand. I'll start off with the question, and this is a question that is DEI. How is it in other countries, other Western countries? Has it taken over their medical education as it has in America?
You know, I can't speak to all of them. We had a very recent experience in Israel as one place that that has confronts a very diverse population, obviously. And there, it's D and I, but there's no E. So they believe in diversity and they believe in inclusion. But the idea that equity should be the result of all this, that is to say that the outcome should be equal for all groups and every group will be represented according to their percentage in the population in terms of admissions, that they feel is not something that they can stand. And their view is that, you know, it should be equality of opportunity, should be the driving force, and that diversity will be a natural occurrence of people seeking opportunity, and the best of the groups that apply will be the ones who get the opportunity. I think, you know, I recall that President Macron of France was complaining several months back about the fact that he saw DEI as something that was being exported from America to Europe, as opposed to something that was so dominant in at least his country. So I think, speaking from recollection of his comments, it's a bigger problem here than any place else.
Mark Blumenthal, could you unmute yourself and pose your question?
Thank you, Dr. Goldfarb. It was very enlightening. I just had one quick question. In all your statistics, do you look at male, female, or are you just looking at race?
Yeah, you know, Mark Perry has some of his efforts, and Mark is someone he's a professor of economics at the University of Michigan, and he's been at this for a long period of time, and he's certainly focused on the issue of when there's specific gender requirements in terms of who has opportunities for programs. We personally haven't done that. We have focused more on the issue of who's gotten excluded and the ones that we've encountered lately, because I think, nowadays, certainly in education, there's such a large representation of women. As you well know, there are more women in schools now in higher education than men. And in medical school, it's a 50-50 proposition. So I think that issue is pretty much been reduced, certainly in the healthcare world, but it still pops its head occasionally. And again, I've made 2 points about this. Maybe I can just expand on this a little bit. So we have a lawsuit that we concluded in the state of Louisiana. That's actually underway. And the reason we sued the state of Louisiana's Do No Harm filed this lawsuit is because they had a rule that the state medical board, which is an important organization because it doles out any punishments if physicians have any sort of behavioral issues or break the law, use drugs, what have you. And the law in Louisiana was that every other appointment to the state medical board had to be a minority individual. And, I was interviewed by NPR down in New Orleans about it. And the question was, why do you object to this? And I said, there really were 2 reasons. There really were 3, but I gave them 2 reasons. One reason is it's just plain illegal. Our country has laws, civil rights laws, the Title VI, that say that you can't do this, that you cannot discriminate on the basis of race. And I said the second reason was, look what you've done to the Black physicians who have earned the respect of their communities, have been recommended by their hospitals. That's who recommends who goes to the medical board. And they're going to be put on the state medical board, and they're going to be viewed as being there simply because of their skin color, rather than that they're highly respected physicians in the community. So every time you do one of these affirmative action things or racial quotas, all you're doing is undermining the minority individuals who totally deserve to be in these positions on their own. And as long as that goes on, we're going to continue to have this divisive sense of it all. So I think that's sort of our thinking about all this. But gender issues have not really been ones that have been a problem in our particular set of topics.
Adrian, you have your hand up.
Yes. Excuse me. I have 2 questions. One is there anti-Semitism within the medical community against Jewish doctors? And the second question is, I believe every patient should be their own advocate. If I were looking for a new physician today based on DEI, you mentioned 8-10 years already in progress,
you might want to stop.
what age limit would I look for a new doctor? 40 years old, 50 years old, so that he would have had the standard treatment that you had.
I'll heat this up.
Does it have any cream in it?
I put chocolate in it.
Okay, yeah, if you could just stick it up.
Oh, what do you like?
Were you able to hear my question?
Yeah, I think so. Anybody who's not on the question should be on mute.
Tomorrow? Okay.
Roz, Michael, you're not on mute.
Thank you. So the questions, I think, the second question is, can you find a doctor that's not involved in DEI? And the first question was, has there been anti-Semitism against Jewish doctors? I'll take the first one first. This has become a real problem. There are a couple of physicians, and they're particularly, I think, they're physicians who have emigrated from the Middle East, who have brought along their political views and have inserted them into the academic or the medical world. And one of them is kind of a famous, infamous one out at, I think she's at University of California in San Francisco, who has said, It's dangerous to go to a Jewish doctor, a Zionist doctor is the way they put it, because of their political views. In fact, it's really sort of been the other way. The doctors that have spoken out for the most part and have, supported Hamas's terrorism have been the ones that are really of concern. And they're not exclusively, but they tend to be physicians whose family origins, what have you, are in the Middle East, and they're bringing this strife along with them to the United States, and they've spoken out about it. The website that's identifying those anti-Semites in medicine and other fields have pointed out a number of physicians, including a couple at the University of Pennsylvania, who were tearing down the posters. If you tear down a poster of a child that's in captivity in Gaza, you're not demonstrating the sort of humanistic qualities that one expects out of a physician. And I haven't seen any Jewish doctors that are calling for and reveling in the misery that the Gazan people have to go through because of what Hamas has done. On the other hand, you see these other physicians who are spewing hate about Jewish doctors, expressing their delight with what Hamas did. And I think that disqualifies them really from being physicians, to tell you the truth. And I'm not sure what level of punishment people are undergoing, but I think anybody who calls themselves a physician who revels in violence and in the misery that has been foisted on the peoples of Israel and Gaza, really has forfeited their right to be a physician, as far as I'm concerned.
Can I just insert one thing came to mind? What about Muslim doctors mistreating Jewish patients?
Well, that's the concern. The concern was expressed. What about Jewish doctors mistreating Muslim patients?
Muslim patients, yeah.
Yeah, I think that we should believe people when they say what they believe, and when these Muslim doctors have gotten in public and attacked and have supported what Hamas did, I think we should believe them that they can tolerate this sort of barbarity. If a Jewish doctor spoke that he was enjoying watching the terrible suffering that's going on in Gaza, I think we should believe him too, that he's lacked or she's lacked the humanity that's required to be a physician. I think it's been very much a one-sided problem so far, but that's my view of it.
And my second question,
right, is that I don't know that it's much of a problem yet. I think it's really been the greatest problem currently after the death of George Floyd and this outbreak of anti-Semitism. I think that the concern is going to be, what's it going to be like going forward? And, inevitably, just as I said, once you start going down the affirmative action pathway and declaring that you're going to focus on diversity above all else, I think patients are going to be rightly worried. Am I going to someone who happens to be there because, of their skin color or their political views or their willingness to support these political views, or are they going to someone who was the most qualified people that were available? And I think patients, knowledgeable patients, often seek out the academic qualifications of their doctor, where they went to school, whether they were honor recipients in their classes. People do that. They look for those certificates on the wall of offices and decide that that's part of their thinking. And I think physicians refer patients to other physicians, again, based on knowing what their academic qualifications are and their skills. So I think if we have a cadre of physicians that are there because of these non-meritorious circumstance issues, it's going to undermine trust, and people are going to be concerned. And we're going to start having patients ask questions like this, like you're asking right now. And it's a legitimate question.
Thank you.
Dr. Goldfarb, two people have asked similar questions. And they're quite different from what the main focus of the presentation was, but they ask about the Democrats that they report that does filling out the demographics play a part in care? I never fill it out because I feel it will affect my care. And someone else said, I also find that the demographics get filled out for me, and it's often incorrect for race. I have to go back and ask to have it removed. It gets very frustrating. So do you think that it actually affects the care that they receive?
I think the rationale for it has been an increasing desire to make this part of the healthcare world. And my own particular suspicion is that there's a kind of a plan underfoot, if you will. I'm not much of a conspiracist, but that there's a plan underfoot to sort of turn all kinds of social programs into healthcare programs. And so that the logic is, if you can say that social conditions produce disease, then the funding for remediating social conditions becomes the funding that goes towards healthcare. And, Medicare has its own funding pathways, so that may be part of the rationale there. And I think that's why they're collecting this demographic information, because the government has decided more and more that it wants to identify how groups of patients are being treated as groups. So, the concern is if they find that there continues to be healthcare disparities for one group versus another, and now they have the group racial characteristic data in hand, that they'll be able to sanction people or institutions that have these kinds of disparate outcomes. But of course, if the disparate outcomes are not because of the way the institution is acting, but it's when the patients are seeking care, for example. And an example of that is amputations for diabetes amongst Black men. It's a terrible problem. And the biggest reason is they're showing up late in the course of their compromised circulation in order to get care that wouldn't require amputations. But when you come too late for anything else to be done but an amputation, you're going to get an amputation. There was a recent article in the Wall Street Journal about uterine cancer, and it turns out that Black women were seeking care for their symptoms 8 months after the symptoms began, and white women, it was an average of 4 months after the symptoms began. You're going to have better outcomes if you show up sooner when you start to have symptoms of a particular illness. So it's a huge educational problem that needs to be confronted, and a huge improvement in access, both people accessing healthcare and the healthcare system providing access, if we're going to really alter the healthcare disparities that exist. What my organization is against is saying, okay, if we just declare our institution anti-racist and we send all our physicians to lots of anti-bias training and we focus on these issues and we get more Black doctors, we're going to improve healthcare outcomes, when in fact the problem isn't any of those things. The problem is a problem of getting access to care.
David.
Thank you. So you might have just answered the question in part, because you've mentioned that there are indeed disparities in healthcare outcomes and healthcare issues for people of various minorities. So what are the solutions that you and your group are suggesting to help do with that, instead of the DEI program that is under consideration?
Yeah, I've said many times the real issue is to improve the access. Now, University of Pennsylvania, I've been complaining about them, and they started all this, but I've been very pleased with kind of approach that institution has taken. Their view of it has been, we've got to get out in the community and provide care into the community. They put together a mobile breast cancer evaluation van, and they sent it out in the community, because if you have a single mom who's got 2 jobs trying to pay for her life, and she doesn't have time to get her mammography, the mammography is coming to her. And this is the sort of thing that needs to be done. If there's a real push to improve healthcare outcomes, it's going to be better education, better organization that delivers care earlier. That business about the amputations that I was talking about, there's a program in Philadelphia focusing on Black men, trying to get them into the healthcare system earlier if they have diabetes and start to experience early symptoms of vascular insufficiency in their legs. It's a question of getting the care out there and getting the patients willing to follow regimens, understanding the problems. That's what's going to improve health outcomes. And each time one looks at this, that's always an element in the process that is just ignored. People find healthcare discrepancies and decide to attribute it to racism because they can't identify the other reasons for it. But the other reasons for it turn out to be patient-based reasons, and it's the patient-based reasons that's a problem. Maternal mortality is another issue. There's a much higher maternal mortality in Black women. Black women have a 40% lower rate of getting first trimester prenatal care than white women do. And that's when the hypertension that they have is discovered. That's when it starts to get treated early. That's what prevents premature deliveries. That's what prevents preeclampsia and other complications of pregnancy. And that's what would reduce maternal mortality. There are also social issues about maternal mortality that need to be addressed too, because many of the deaths occur within 6 weeks after the delivery of the baby. These women are not dying in the hospital. They're dying before and they're dying after, and they're dying because of lack of access of good care. Again, at Penn, they have a program where they send women home with a telemedicine blood pressure cuff so that they get their blood pressures measured after the delivery for 6 weeks after the delivery. If they have episodes of hypertension that are poorly controlled, their physicians now know about it and can bring them in and start to treat them. So, this is a very complicated issue, but to simply attribute it to the most easily accessible problem, which is supposedly racism on the part of the healthcare system, is not going to help anyone. And these kinds of interventions are what really need to be done. And I think that's really the answer that we've proposed over and over again.
Charles Rose, I'm sorry if I didn't see you before.
That's all right. I appreciate that. First of all, I really appreciate your commentary. I'd like to make one observation, and I'd like your response if possible. Your analysis of the healthcare side is very informative, but it's a microcosm of a broader issue of which the DEI, I happen to run a hedge fund. My wife is a graduate of UPenn. I am not.
Uh-huh.
I'm a PhD engineer. I went to business school afterwards, and I've been on Wall Street for 40 years. So the same issues of DEI have been occurring in corporate America on boards. The same issue of DEI has been occurring in government. The same issue of DEI has been occurring in throughout the whole system. So it's not unique to the healthcare system. And more importantly, we're at a juncture now where you're seeing a degradation of our government issues, our government debt. We're seeing degradation of universities. We're seeing degradations across the whole system where the Jewish people, I happen to be Jewish, I'm Orthodox, the Jewish people are now become a target, an enormous target, and a target of what I call a reversal of we are now the perpetrators of crimes.
Right.
We are the criminals across the world, not just in Israel, but we're the criminals across the world. So now the question I have is, how can you take your narrative and take it to a new level where it can become more relevant to addressing the issues of DEI? Because DEI is not limited to the medical industry. It really has broader implications to our society. It's not limited to the medical industry. I'm not trying to criticize you. I love what you're doing, and I really have a tremendous amount of respect. But how do you take what you're doing and bring it to a higher level of applicability, of change that's going to address a more societal impact?
Yeah. Well, look, Mr. Rose,
that's a $64,000 question to me.
That's a big question. Our organization has been, I think, pretty successful, and we've been pretty successful because of a very, very narrow focus. So, and it's by sticking to our issues about DEI, we've able to pass a number of laws in Midwestern states. We've been involved in passing 23 laws in the Midwest about so-called gender affirming care, which is another issue that we could get to, which has implications here as well. But we've kept our focus very tightly on this area. We've looked to produce legislation that was going to make change. And, what we're trying to do, and we're arguing for getting DEI out of schools. I mean, ultimately, all this sort of goes back to the educational system when all is said and done. What's what's going on in elementary school now is what's going to influence the high school kids of the future and the college kids, and they become the professors, and they become the physicians and others in the future. So I think that the educational efforts that we have in higher education, I think, are really important. I ultimately think all this is about education, but this is a massive societal issue. What's happening to the Jewish people right now? I am Jewish as well. We're the target of a very concerted campaign using social media and political organizations and international organizations and media that have all been, they sort of conspired. I mean, that's not too strong a word to use, to present this picture of the Israeli people as a people that are harming the Palestinians, and this is finally getting their comeuppance. When in fact, anyone who's sentient understands that there's a many centuries view of this whole issue. The history of Israel is very complicated and goes back at least 150 to 160 years for modern Israel about what the interactions between the Palestinians and the Jews are. And, unfortunately, the education system is portraying this in such a one-sided way, and the media is portraying it in such a one-sided way that it's getting incredibly distorted and to our detriment. I think these are problems that go well beyond do no harm. These are problems of the media. These are problems of government. These are problems of the educational system as large. We're focusing on the medical side of things. Hopefully, there's going to be other groups that are going to focus on the issue in schools, and I'm sure that's starting to happen as well.
I think your only mistake that you're saying is that it's not limited to Israelis. It's a global attack on the Jewish people.
No, I understand. We're all Israelis as far as they're concerned.
Exactly. We are all Israelis.
I know.
Dr. Goldfarb, I just want to mention, for the benefit of whoever here is involved in the healthcare industry, there is an organization, I believe it's the American Association of Public Health. I may be mistaken, but they have a proposed resolution, C5, extensive resolution that's being proposed before the association, which is extraordinarily critical of Israel and extremely biased. It's open for members of the organization to comment, and I just want to mention that before we go on. Anna, you had your hand up.
Hi. The one that wrote, well, it was anonymous first and then my name second, about the demographic form. And I asked that because I have seen multiple times where they fill it out for me and they put in the incorrect race. And I don't know why they do that. And I go in and say, I've repeatedly asked to leave my demographics off. And now I've seen that you filled them out for me. Is that even legal? Which I don't ever, of course, get an answer because they can't do that, I'm assuming. But also, I would like to say that you were talking about Jewish doctors. I'm sorry. I can't remember what we were talking about, but I personally, as a patient, have lost to white female physicians due to anti-Semitism. So I think, one, you did bring up about that you're not checking, your organization hasn't looked at male-female. I do think that is a really important aspect to look to in the future, the impacts on female. And then also, it is happening that Jews are being dismissed by their doctors for being Jewish.
Really? Well, that's worthy of reporting. Let me say,
I don't even know where to go about that.
Well, you should let us know, because our organization has has access to the print media and has access to legal help And if that can be really ascertained, I mean, that's the sort of thing that the public should know about, and these physicians should be sanctioned over.
As to Charles Rose's question, about the bigger problem, we have somebody in the audience who is a specialist in DEI. She was prominently involved in California at a community college, which dismissed her because she, although a Black woman, she was interested in actually having diversity and wanted to bring programming against anti-Semitism. And that wasn't popular there, to say the least. She suggested that she's involved with a coalition for empowered education, which is addressing the big issue of DEI and toxic critical social justice. I'm not sure. I don't think I've ever heard the first name, whether it's Tabia or Tabia. I'm not sure how to pronounce it. But Ms. Lee, is there something you wanted to add to that?
No, I was just here as a listener. It's Lee. I go by Lee. Thank you for the heads up there. But in the Coalition for Empowered Education, we are actually working on some of the issues, the educational issues in K through 12 and higher ed, which would also impact medical schools and other spaces. This critical social justice ideology, which is toxic for Jewish people, for white people, for so many people, is something that we are looking at, and that we are developing alternative frameworks for teachers to use and guiding principles and standards and resources, because that's what teachers really need. The critical social justice advocates and scholar activists have been very effective with getting their information out into medical schools, K through 12 schools, and all aspects of American education. So we need organizations and people who are diligently working to counter that with resources that teachers can use and networks for teachers. So I dropped the link to our website there in the chat, and hopefully some folks will join us in May when we have our launch conference for the Empowered Social Justice resources. So thank you for that.
Dr. Lee works with us at Do No Harm as well, so I know her very well, and she's a fantastic person and a fantastic organization she represents as well.
So one other person asks, has DEI concretely affected the standards whereby medical students qualify for licenses? I think you mentioned before, Dr. Goldfarb, that it's the minimum standards aren't really what we're looking for, and the fact that people can pass minimum standards isn't really shouldn't be the test. But then the question I suppose is whether the minimum standards have been compromised.
No, I don't think the minimum standards have been compromised, except for the fact that now the first part of the licensure exam, which is a 3-part exam over several years, is a pass-fail exam. It used to be a graded exam. You still have to pass it, but the point of it in the past was it functioned almost as an achievement test for the more competitive training programs like ophthalmology and dermatology and neurosurgery. They used to look at the grades on that exam to give them some idea of what the academic potential was for the students. Now they don't have that anymore, so now that they have to go by grades. But of course, as I mentioned, 97% of people pass, and the grades are inflated in medical school just as they are in every other part of higher education. So it's turning out that this is, and the rationale for getting rid of that grading system in the first part of the exam was simply that not enough minority students were qualifying for the most competitive specialties. Because, for example, they'd have 4 or 5 training positions, they'd get 1,000 applications in. So the first cut was always scores on that exam. And then once they picked the students with the highest scores on that exam, then they went into the details of the applications. So if you didn't get a good grade to begin with, you're never going to have an opportunity to compete for one of these highly desired slots that were very, very limited in number in the country. I guess in that sense, the standards have been lowered, but whether this is going to play out in the way that it might play out, I hope it doesn't, but it may.
Dr. Goldfarb, I know we're a couple of minutes late,
yeah,
but
maybe
I was going to ask if you have time for one last question.
One last one.
Adrian
Stephen, not a question. Excuse my voice, another physician friend of mine told me about a new organization, American Jewish Medical Association. It's Jewish doctors fighting anti-Semitism.
Yes, we know of them. We work with them as well. I know Dr. Schwartzbach is one of the members of the board there, and I've communicated with him, and we're working with them to try to help them as well.
Thank you so much, Dr. Goldfarb, for coming, and really appreciate it, and hope your organization has success. I'm speaking for myself, of course, and we look forward to hearing your testimony tomorrow before Congress.
Thank you so much. Bye, everyone.
Bye-bye.
Thank you.